Today we will read about pleural effusion. Pleural effusion, a collection of fluid in the pleural space, is rarely a primary disease process, but is usually secondary to the other diseases. Normally, the pleural space contains a small amount of fluid, 5 to 15 ml, which acts as a lubricant that allows the pleural surface to move without friction. Pleural effusion may be complication of a heart failure, TB, pneumonia, pulmonary infections, particularly viral infections, nephrotic syndrome, connective tissue disease, pulmonary embolism, and neoplastic tumors. Bronchogenic carcinoma is the most common malignancy associated with the pleural effusion. Pathophysiology. In certain disorders, fluid may accumulate in the pleural space to a point where it becomes clinically evident. This almost always has pathologic significance. The effusion can be composed of a relatively clear fluid, or it can be bloody or purulent. An effusion of clear fluid may be a transudate or an exudate. A transudate filtrates of plasma that move across intact capillary walls occurs when factors influencing the formation and reabsorption of pleural fluid are altered, usually by imbalances in hydrostatic or oncotic pressures. The finding of transudative effusion generally implies that the pleural membranes are not diseased. The most common cause of transudative effusion is heart failure. An exudate, that is extravasation of fluid into the tissues or a cavity, usually results from inflammation by bacterial products or tumors involving the pleural surfaces. Clinical manifestations. Usually, the clinical manifestations are those caused by the underlying disease. Pneumonia causes fever, chills, and pleuritic chest pain, whereas a malignant effusion may result in dyspnea and coughing. The size of the effusion and the patient's underlying lung disease determine the severity of symptoms. A large pleural effusion causes shortness of breath. When a small to moderate pleural effusion is present, dyspnea may be absent or only minimal. The severity of the symptoms assessed depends on the time course of the development of the pleural effusion and the patient's underlying disease. Assessment and diagnostic findings. Assessment of the area of the pleural effusion reveals decreased or absent of breath sounds, decreased fremitus, and a dull, flat sound when percussed. In an extremely large pleural effusion, the assessment reveals a patient in acute respiratory distress. Tracheal deviation away from the affected side may also be noted. Physical examination, chest X-ray, chest CT scan, and thoracentesis confirm the presence of fluid. In some instances, a lateral decubitus X-ray is obtained. For this X-ray, the patient lies on the affected side in a side-lying position. A pleural effusion can be diagnosed because this position allows the layering out of the fluid and an air fluid line is visible. Pleural fluid is analyzed by bacterial culture, gram stain, gram-facet bacillus stain for TB, red and white blood cells counts. Chemistry studies includes glucose, amylase, lactic dehydrogenase, protein. Cytologic analysis for malignant cells and pH. A pleural biopsy also may be performed. Medical management. The objectives of treatment are to discover the underlying cause, to prevent reaccumulation of fluid, and to relieve discomfort, dyspnea, and respiratory compromise. Specific treatment is directed at the underlying cause. Example, heart failure, pneumonia, lung cancer, cirrhosis. If the pleural fluid is an exudate, more extensive diagnostic procedures are performed to determine the cause. Treatment for the primary cause is then instituted. Thoracentesis is performed to remove fluid, to obtain a specimen for analysis, and to relieve dyspnea and respiratory compromise. Thoracentesis may be performed under ultrasound guidance. Depending on the size of the pleural effusion, the patient may be treated by removing the fluid during thoracentesis procedure or by inserting a chest tube connected to the water seal drainage system or suction to evacuate the pleural space and re-expand the lung. If the underlying cause is a malignancy, however, the effusion tends to recur within a few days or weeks. Repeated thoracentesis result in pain, depletion of protein and electrolytes, and sometimes pneumothorax. Once the pleural space is adequately drained, the chemical pleurodesis may be performed to obliterate the pleural space and to prevent reaccumulation of fluid. Pleurodesis may be performed using a thoracoscopic approach or via the chest tube. Chemically irritating agents, example bleomycin or talc, are instilled in the pleural space with the chest tube insertion approach. After the agent is instilled, the chest tube is clamped for 60 to 90 minutes and the patient is assisted to assume various positions to promote uniform distribution of the agent and to maximize its contact with the pleural surfaces. The tube is unclamped as prescribed and chest drainage may be continued for several days longer to prevent reaccumulation of fluid and to promote the formation of adhesions between the visceral and parietal pleurae. Other treatments for malignant pleural effusions include surgical pleurectomy, insertion of a small catheter attached to the drainage bottle for outpatient management, or implantation of a pleuroperitoneal shunt. A pleuroperitoneal shunt consists of two catheters connected by a pump chamber containing two one-way valves. Fluid moves from the pleural space to the pump chamber and then to the peritoneal cavity. The patient manually pumps on the reservoir daily to move fluid from pleural space to the peritoneal space. Nursing management. The nurse's role in the care of the patient with the pleural effusion includes implementing the medical regime, and next one is positions the patient for thoracentesis, and the third one is pain management is a priority. Assist the patient to assume positions that are least painful. Frequent turning and ambulation are important to facilitate drainage. The nurse administers the analgesics as prescribed and as needed. If the chest tube drainage and water seal system is used, the nurse is responsible for monitoring the system's function and recording the amount of drainage at prescribed intervals. If the patient is to be managed as an outpatient with a pleural catheter for drainage, the nurse is responsible for educating the patient and family regarding management and care of the catheter and drainage system. Thank you.